think we will start now. Bismillah ar-Rahman ar-Rahim. Bismillah ar-Rahman ar-Rahim. Wassalatu wassalamu ala ashraf al-mursaleen Sayyidina wa Nabiyyina Muhammad sallallahu alayhi wa sallam wa ala alihi wa sahbihi wa sallam. Tonight, we thank again GSK company for supporting this webinar. And really, they are a real partner with us. And tonight, we're going to talk about lupus nephritis in Saudi Arabia. I'm happy to introduce our moderator. He is Dr. Uday Al-Harbish. He's a consultant pediatric nephrology, associate professor at King Saud University, and he is going to be our moderator for tonight. Of course, he is qualified as a bachelor degree from King Saud, and then he moved to Canada, where he get his Royal College Fellowship in Pediatric, and then he proceeded to Pediatric Nephrology. He has a great number of publications, and he's an excellent teacher. Without any delay, I will leave the microphone to Dr. Uday. Thank you, Dr. Uday.
Thank you, Professor Mutwalli. Good evening, everybody. Wassalamu alaikum wa rahmatullahi wa barakatuh. It's my pleasure to chair this webinar. And I would like to thank the Saudi Society of Nephrology, Dr. Khalid Al-Hassan and Professor Mutwalli and their colleagues for the great teaching activities that they are arranging. They're really taking care of us. It's my pleasure to chair this webinar, which will be presented by Dr. Najla Zabani. Dr. Najla is the head of the nephrology unit in King Faisal Specialist Hospital and Research Center in Jeddah. She did her internal medicine and nephrology and kidney transplant in London, Ontario. And she has a lot of publications in kidney transplant and infections in kidney transplant. And we will hear her tonight speaking about lupus nephritis in Saudi Arabia. So the talk will be around 40-45 minutes, and then 15 minutes for questions. And feel free to write your questions in the Q&A section. Dr. Najla.
Assalamu alaikum, everyone. Thank you, Dr. Uday, for the introduction. First of all, I would like to thank the Saudi Society of Nephrology for having me today. Today, I'm going to talk about lupus nephritis in Saudi Arabia. And as we all know,
Dr. Najla, we cannot hear your voice.
Yes, I'm trying to just flip the slide. I think I have technical difficulty.
Now it's perfect.
Yes. So basically, as we all know that SLE is a chronic multisystemic autoimmune disease that is marked clinically by multisystemic inflammatory involvement. The course and the prognosis of SLE are highly variable, as well as the clinical features of SLE have been extensively described from different geographical parts in the world, with some variations among different racial groups. When it comes to lupus nephritis, it's been found that it can occur in up to 50% of patients with SLE worldwide. And lupus nephritis is considered a major risk factor for morbidity and mortality in SLE patients. As it's been reported in the literature, it can lead to up to 10 to 30% of patients with lupus nephritis may progress to kidney failure, requiring renal replacement therapy. And a mortality rate of 5 to 25% within 5 years of onset, especially in patients who have proliferative forms of lupus nephritis, specifically class 3, 4, or class 3/4 and class 5 are considered the highest risk group for requiring renal replacement therapy and mortality. In terms of the prevalence of lupus nephritis, it tends to vary considerably between different regions in the world and different races and ethnicities. As you can see here, this table, it shows the prevalence of SLE and lupus nephritis among different racial groups. And when you look down at the bottom of this table, you will see that Black African Americans, they tend to have the highest incidence or prevalence of lupus nephritis of about 69%. Asians and Hispanic, they have lower incidence than Black African Americans. However, white Caucasian tend to have the lowest prevalence of lupus nephritis compared to other ethnic groups of about 29%. The reasons behind these racial and ethnic differences are not completely understood. However, there are some genetic or socioeconomic factors that may contribute to these racial variations. What about our local data on lupus nephritis in Saudi Arabia? Well, there are so many studies published locally that showed the prevalence of lupus nephritis is quite high in the Kingdom of Saudi Arabia. It can vary between 48 to 66%. And not only that, but lupus nephritis has been found to be the most common cause of secondary glomerular nephritis among all glomerular diseases. And this was actually confirmed by a study published earlier in 2000 by Prof. Mutwalli that basically looked at the prevalence of glomerular nephritis in the Kingdom of Saudi Arabia at different time periods, starting from 1984 until 1999. And when you look at that table, you will see that lupus nephritis was the most common secondary glomerular disease among all glomerular diseases. Another study along the same line was published recently by Dr. Al-Hamrani in 2019 that looked at the pattern of renal diseases based on renal biopsies that were done. This is actually a prospective multi-center trial that involved different patients from different institutes from different regions in Saudi Arabia. And again, they found that lupus nephritis was the most common cause of glomerular disease among all secondary causes of glomerular nephritis. But the prevalence here was slightly higher than the prevalence that was published earlier in Dr. Mutwalli's study. The prevalence here was 66%. And when you compare the literature, you will see that basically the incidence is increasing, not because there is a change in the disease characteristic, but because maybe we are changing our practice and we're screening more patients and detecting the disease earlier on. Not only in adult, lupus nephritis was very common, but also in children. Dr. Al-Hassan did a study on children looking at the renal histopathology spectrum in children with kidney diseases in Saudi Arabia. They actually have a total of 326 children who underwent kidney biopsy from 1999 till 2017. And again, they found that lupus nephritis was the commonest cause of secondary GN among children of about 69.8%. Now, if you want to get an insight of how does lupus nephritis behave in Saudi Arabia and what are the characteristics of those patients and how is their outcome, this study looked at all these details in a large cohort of patients where they included 624 cases of SLE in Riyadh, was published by Dr. Al-Arfash in 2009. The aim of this study was to look at the prevalence and the clinical and laboratory features, in addition to the histological types of lupus nephritis, as well as the therapy and renal outcome in patients with lupus nephritis in Saudi Arabia. A retrospective study that covered a period of 27 years between 1980 until 2006. They had a total of 624 SLE patients who were referred to King Khalid University Hospital in Riyadh. The diagnosis of lupus nephritis was made back then by the presence of at least one of the following criteria. Either presence of persistent proteinuria, which was defined as having proteinuria greater than ½ gram per day, persistently elevated serum creatinine, or the presence of active urinary sediment, or renal biopsies that were performed when clinical or laboratory signs of renal involvement were observed. And out of the 624 cases of SLE, they actually diagnosed 299 patients with lupus nephritis, which gives an incidence of about 47.9% of lupus nephritis in Saudi Arabia. And this incidence or prevalence is actually comparable to the prevalence that was published in Dr. Mutwalli's trial. When you look at their baseline characteristics, you will find that the majority of patients were Saudi. About 88% of patients were Saudi. And male, actually, they had, this is actually in reverse at the table. Male actually constituted only 10% of total lupus nephritis patients, while female had almost 89% of them were affected by lupus nephritis. And that gives a ratio of female to male ratio of 8.3 to 1, which is comparable to the international literature. When you look at the age of onset, you will find that the majority of patients were between age of 16 and 50. About 74% of patients were diagnosed with lupus nephritis between age of 16 and 50. Pediatrics constituted only 2% of those patients. The mean age of disease onset was found to be 23 years, plus minus 10 years. The mean duration of follow-up in this study was 6.6 years. The mean duration of the disease was around 9.3 years. About 3.9% of patients were having lupus nephritis for over 20 years. When you look at the extrarenal manifestation of lupus nephritis, you will see that the most common extrarenal manifestation in patients was hematological manifestation in about 87% of patients, while the second most common extrarenal manifestation was arthritis in about 69%. Mucocutaneous manifestation also was very common at the time of presentation with lupus nephritis. Hypertension was present in about 45% of patients with lupus nephritis, and 13% of patients who had lupus nephritis, they had concomitant antiphospholipid syndrome. And when you look at the laboratory parameters at the time of presentation, you will see that when they presented with lupus nephritis, the majority had anemia. About 76% of patients with lupus nephritis, they had anemia. Only 25% of patients, they had elevated serum creatinine at the time of presentation. And also 50% had depressed levels of C4 and C3. When looking at the 24-hour urinary protein excretion, the majority of the patients, when they presented with lupus nephritis, they had a range between 0.5 gram and 3.5 grams, subnephrotic range proteinuria. But the nephrotic range proteinuria occurred only in 20% of the patients. When you compare that to the international literature, their reports of nephrotic range proteinuria above 3.5 grams was much higher than ours. About 26 to 48% was present in patients with lupus nephritis. Creatinine clearance, the majority had creatinine clearance less than 75 ml per minute at presentation. Around 65% of patients had low creatinine clearance, but significantly depressed creatinine clearance of less than 25% was present only in 23%. In comparison to the international literature, the presence of a low creatinine clearance below 25 ml per minute was present to 28% in international reports, which is comparable to our report. In terms of histological classes, at the time of presentation, the majority of patients had class 4 lupus nephritis in about 37%. Class 2 was the second most common class that was present at the time of diagnosis. Class 3 constituted only 10% of patients with lupus nephritis, and class 5 occurred in 11% of the patients. And when we talk further about other studies, you will see the same finding that class 4 was the most common class of lupus nephritis among all patients with SLE. In terms of therapy, basically patients were exposed to different types of protocols and immunosuppression, but the majority were on steroid, and the majority got IV cyclophosphamide in about 65%. And followed by azathioprine was given to around 43% of patients, but that was before the era of MMF. So the majority were on steroid, cyclophosphamide, or azathioprine. Now, when we look at the renal outcome at the time of last follow-up, basically they looked at the remission rate across all cohort groups, and then looked at the remission rate in comparison between the different classes nephritis. So across all the cohort groups, 75% went into remission. And when you look at different classes, the highest rate of remission was found in class 2 lupus nephritis, as compared to class 5 had the lowest remission rate of 68%. And there was a statistical difference between the classes in terms of remission rate. So it was highest among class 2, lowest among class 5. Renal flares occurred in about 4.7% of the total cohort groups, but there was no difference, a statistical difference between the histological classes in terms of renal flare. Development of end-stage renal disease occurs in almost 9%, which is in comparison to the international data. They reported 10 to 30% occurrence of renal failure. So our data showed that the incidence of renal failure might be lower than the international data. Death rate occurred at about 6%, and that is comparable with an incidence of 5 to 25%. Again, there was no statistical difference between the histological classes in terms of development of end-stage renal disease or death. And when they looked at the major causes of death, sepsis was number 1 and renal failure as well. In terms of survival rate, they measured the 5-year patient survival, which was about 6%, while the 10 years patient survival was 95%. And that is higher in comparison to the international studies that reported a survival rate of about 83 to 92%. In this study, they looked at some of the risk factors for poor patient survival, and they found that older age at disease onset, when the age is above 50, was a major risk factor. In addition, of development of diagnosis was another risk factor for poor patient survival. Also, low complement, C3 complement, was another poor predictor for patient survival. They also looked at risk factors for progression to end-stage renal disease in the whole lupus nephritis patient, and they found that the following were poor predictors. Again, older age, older than 50 years of age, presence of hypertension at the time of diagnosis, elevated serum creatinine, presence of histological class 3 or histological class 4 were all risk factors for progression to end-stage renal disease in lupus nephritis patients. When they did survival analysis, dividing patients into 3 different time periods between 1980 until 1990, and then between 1991 till 2000s, and between 2001 till 2006, they found no difference in survival between the 3 subgroups, presenting at different time periods, despite an improvement in the treatment modalities that has been introduced to manage lupus nephritis effectively. Again, they compared survival among different histological classes, and there was no survival difference among different histological classes of lupus nephritis. So what we learned from this study, that the prevalence of lupus nephritis in SLE patients was found to be 47%. Was the most common lupus nephritis class, which is similar to the majority of the studies that were reported worldwide. There was a high rate of patient survival of about 96% at 5 years and 95% at 10 years, which was found in lupus nephritis patients. Risk factors for poor patient survival included older age at disease presentation, above age of 50, development of end-stage renal disease, and low C3 complement. Risk factors for progression to end-stage renal disease included older age at disease presentation, presence of hypertension, elevated serum creatinine, and presence of proliferative lupus nephritis histology, class 3 or class 4. Now, this is another study that was published by Dr. Abdullah Malki, looking at the remission rate and the long-term outcome in patients with proliferative lupus nephritis. In this study, actually was a retrospective observational trial. The aim was to examine the rate of short-term remission at 6 months to the standard care of induction therapy, and to assess the predictors of remission, and also to examine the effect on long-term renal outcomes in Saudi patients with proliferative lupus nephritis. They included all adult patients who are above the age of 18 with biopsy-proven focal or diffuse proliferative lupus nephritis who were diagnosed over the period between January 2006 until June 2017, with the information on induction treatment and assessment of the 6-month remission status. They conducted the study in 4 different hospitals in Saudi Arabia. Their primary outcome was to look at the remission rate of biopsy-proven proliferative lupus nephritis at 6 months of induction therapy. The secondary outcomes included looking at the patterns of disease presentation, identifying the predictors of remission, describing the pattern of practice with regards to the induction therapy, and to estimate the rate of long-term outcomes, including doubling of serum creatinine, the rate of relapse, dialysis, and mortality rate. When you look at their baseline characteristics, you'll find, again, the majority they had at baseline, at presentation, they had anemia. In about 82%, they had anemia. Again, the majority of the patients with lupus nephritis had similar to the previous trial of Dr. Al-Arfash. In terms of elevated creatinine above 133, it was found in 32% of the patients at the time of presentation. Nephrotic range proteinuria was present in about 37% of patients with lupus nephritis. And again, class 4 was the most common class diagnosed at the time of presentation in about 63% of patients. Requirement of dialysis occurred in 10% of patients, while 5% of patients required dialysis permanently. In terms of pattern of practice with induction therapy, along with steroid, which all patients got steroid, they either were subjected to receive cyclophosphamide or MMF as a first-line induction treatment. In the majority of patients, in about 90%, were receiving either cyclophosphamide or MMF. However, MMF was used as first line more frequently than cyclophosphamide. 47% got MMF versus 43% received phosphamide. On the other hand, compared to the patients who received MMF, cyclophosphamide-treated patients tended to have more severe disease with higher blood pressure, higher serum creatinine, and higher urine protein excretion, which is the common practice that we have worldwide, that patients who have severe presentation with lupus nephritis, we tend to prefer cyclophosphamide rather than MMF. There were more patients who required dialysis within 6 months at the cyclophosphamide group. And as you can see here in this table, the type of induction therapy and the disease severity. Again, people who receive cyclophosphamide tend to have more hypertension, 50% as opposed to 37% in the MMF group. Patients who received cyclophosphamide had also higher creatinine, serum creatinine, about 39% of them, as opposed to 33% in the MMF group. Nephrotic range also proteinuria was higher among the group who received cyclophosphamide, 49% of them, as opposed to 29% in MMF group. When we look at the temporal change in the pattern of practice, you will see that MMF use as a first line increased over time. Before 2012, actually it was about 42%, but after 2012, it increased up to 58%, while the use of cyclophosphamide had dropped significantly as compared to 2012 and after 2012 from 45% down to 39%. With regards to the severity of presentation at diagnosis, they were a bit different when they looked at them before 2012 and after 2012. So compared to the earlier period before 2012, the median urine protein level was lower in patients who were diagnosed before 2012, was about 2 grams a day versus 3 grams a day before 2012. The median serum creatinine level was numerically lower for patients who were diagnosed after 2012, being 66 versus 95 millimole per liter. So this might be explained by the fact that we're actually changing our practice and we're screening patients earlier and detecting their disease earlier rather than changing the disease characteristics. In terms of the rate of remission of all patients who were treated with nephritis, a total of 67% of all patients, they achieved remission. 39% of them went into complete remission, while 28% they had partial remission. And remission was much higher for patients who had class 3, and 85% had remission, more than class 4, where only 62% achieved remission. When they looked at the remission rate in comparison to the baseline characteristics and the induction therapy, they found no difference between remission rate and exposure to the type of induction. So there was no difference between the group who had cyclophosphamide versus MMF in terms of their remission rate. However, the only difference was found in the histological activity. So people whom they have active disease in their histology, they tended to go into more remission as compared to those who have chronic disease or active/chronic disease in their histology. So histological activity was thought to be a predictor of remission in patients with proliferative lupus nephritis. At the median follow-up of up to 48 months, 95% of patients were alive, and after 6 months, they actually looked at the long-term dialysis patients who required dialysis, and they were found to be around 11% were on long-term dialysis, while peritoneal relapse developed in 10% of patients after 6 months from therapy. Serum creatinine was doubled in about 23% of patients with proliferative lupus nephritis. This table actually looked at the long-term outcome in comparison to the 6-month remission status. And what they found here basically that patient survival and renal survival was significantly lower in patients who had no remission as opposed to those who achieved complete remission and or partial remission with significant p-value. In terms of long-term renal replacement therapy after 6 months, again, there was a significant number of patients who had been on long-term dialysis and in the no remission group, as opposed to the patients who achieved complete or partial remission with significant statistical difference. Again, doubling of serum creatinine was found to be higher among those who had no remission in comparison to those who achieved complete or partial remission. Relapse was not statistically different between the 3 groups. This is a survival analysis looking at the renal survival among the 3 different groups based on their remission status. So as you can see here, that people who attained complete remission or partial remission, they had higher survival as compared to those who had no remission. They had much lower renal survival. And the cumulative rate of doubling creatinine was found to be 73% in 5 years among all patients with proliferative lupus nephritis. And attaining remission was associated with better renal survival without doubling serum creatinine. The cumulative rate of survival without doubling serum creatinine at 5 years was found to be 89% in the group that attained complete remission, 77% for those who had partial remission, and 42% for those who had no remission. The study, the mortality rate was 5.2% who died over the follow-up period. And again, the major cause of death was sepsis, followed also in this trial by GI bleeding. So what we learned from this trial that approximately 2/3 of patients with proliferative lupus nephritis, they developed remission in response to the standard induction therapy. And remission was negatively associated with the presence of renal biopsy. Overall, MMF was the most commonly used agent to induce remission. However, with more severe disease, cyclophosphamide is used more frequently. Patients with proliferative lupus nephritis tend to have significant long-term renal outcomes, including 26% cumulative rate of doubling of serum creatinine at 5 years. And initial remission can predict this long-term renal survival. Now, Dr. Sueda looked at the same patient profile with proliferative GN in a different perspective. He actually divided them into 2 groups based on the presence or absence of necrotic lesions. And they looked at the long-term outcome in those patients with proliferative GN in comparison between those who had necrotic versus those who had no necrotic lesions. The aim of that study was to examine the clinical significance lesions in proliferative patients with proliferative lupus nephritis. and the impact on the of necrosis on the probability of doubling initial serum creatinine or development of end-stage renal disease at final follow-up in patients with proliferative lupus nephritis. They had a total of 52 cases with biopsy-proven proliferative lupus nephritis between the year of 2000 and until 2012, who were diagnosed at King Khalid University Hospital. They divided them into two subgroups according to their histological necrosis. Sorry, I just can't see the top part of my slide here. Okay. So basically, those patients basically received induction therapy consisting of maximum of 6 monthly boluses of IV cyclophosphamide and corticosteroids, and then after induction, those patients were either given IV cyclophosphamide Q3 months or azathioprine. And since the introduction of MMF in 2004, MMF has been used for both induction and maintenance phases. When they compared their baseline characteristic between those patients with proliferative lupus nephritis whom they had necrosis versus those who didn't have necrosis, they came up that basically out of 52 patients, 25 patients had necrosis, which constitute about 48%, while 27 had no necrosis in their histology, which constitute 51%. They actually found that looking at their baseline parameters, patients with necrosis tend to have more active in comparison to those who had no necrosis. The 24-hour urinary protein was much higher in those who had necrotic proliferative lupus nephritis as opposed to those who had no necrosis. Again, serum creatinine was much higher in patients with necrotic lesions in comparison to those who had no necrosis. Also, serum complements level were much suppressed in patients with necrotic lesions. Also, the activity index was as well as the chronicity index was much higher in patients with necrotic lesions as opposed to those who had no necrosis at baseline biopsy. In terms of renal outcome, when they looked at the renal outcome after a median follow-up period of 8.8 years, they found out that patients who had necrosis, basically the no remission rate was much higher in patients who had no necrosis in their renal histology in comparison to those who had no necrosis. So again, no remission was much higher in patients with necrotic lesions. Also, doubling of serum creatinine was much higher in patients with necrotic lesions, as well as the activity index and chronicity index were much higher in those patients as well. And just of note that the management protocols between the two groups were not different. So the conclusion from this study was that glomerular necrosis identifies lupus nephritis patients who are at higher risk for progression to renal failure. Therefore, a proactive intervention and possibly more aggressive induction therapies in patients with necrotizing lesion may protect the kidney from developing chronic renal impairment. Now, a common question that always comes up in practice, whether there is any role for doing a second kidney biopsy in patients who are treated for lupus nephritis in order to guide us on the therapy and to assess the prognosis of those patients and to assess the response to therapy as well. This actually question was nicely answered by Dr. Asweda in this trial that was published in 2012 on the strategy for second biopsy in patients with lupus nephritis. The objective of this study was to examine the predictive utility of a second kidney biopsy in patients with lupus nephritis to discriminate active from chronic disease. It is a longitudinal study that looked at the predictive power of a second kidney biopsy and the long-term outcome of renal function. It was conducted between 1996 until April 2009 for the first biopsy. Patients were having biopsy-proven lupus nephritis at the first presentation. They were actually advised to have a second biopsy to assess their disease activity at the end of maintenance therapy, which was around 12 months from the initiation of induction. Followed for about 8.7 years, beginning in 1996. Their clinical and biochemical parameters were collected annually. So they had a total of 77 patients who completed the study. And they compared each patient class between the first and the second biopsies, and they examined the probability of doubling of initial serum creatinine at the final follow-up visit. Most patients were exposed to, most patients actually were falling under class 3 and 4 lupus nephritis, and they were actually exposed to steroid and cyclophosphamide as induction therapy, followed by IV cyclophosphamide Q3 months or azathioprine as a maintenance therapy. And when MMF was introduced in 2004, they were actually using it for both induction and maintenance. Class 2 lupus nephritis patients were subjected to steroid and azathioprine. Okay. When you look at their baseline characteristics here, you will see that basically the majority of the patients were actually having class 4 lupus nephritis at the time of first biopsy. And the majority actually had been exposed to cyclophosphamide. Only 20% got MMF as induction therapy, and only 10% received azathioprine. Out of the majority of people who received cyclophosphamide, out of them 55% were given azathioprine as a maintenance therapy. So when they looked at the first biopsy, the baseline histologic and laboratory characteristic, they found out that basically complete remission occurred in about 41%, while partial remission occurred in 23%. And when they compared the remission rate in comparison to their clinical or histological presentation, basically they found no difference between baseline proteinuria, presence of active urinary sediment or complement levels, or level of anti-DNA antibodies, or presence of activity or chronicity indices in the biopsy, and the probability of achieving complete or partial or no remission. So there was no relation between the remission status and these biopsy. However, at the second biopsy, when they compared the laboratory and histological characteristics, they found that patients who had no remission, they tended to have C3, a low C3 level at the time of second biopsy. So a low C3 level correlated with poor prognosis or increased probability of no remission. In terms of histological changes between the first and the second biopsy, when they did the second biopsy, they noticed that 41% of patients with lupus nephritis, they had no shift in their class. However, 55 patients, they had a pure class 2 to 4 at the first biopsy. 20% of them, they had histological shift to another class in the second biopsy. But none of those patients who had class 2, 3, or 4, they shifted into class 5. So the incidence of change from one class to another class was around 60%, especially in patients who had no remission, 41% in those who had partial remission, and was found to be 65% in patients who achieved complete remission. And of note that the proportion of patients with class 3 and 4 were not significantly different between the three groups who achieved the complete remission or partial remission or no remission. They did survival analysis. They found out that renal survival basically was much higher among those patients who had complete remission. And it was found to be at 10 years, 93% for those who attained complete remission, in comparison to 69% for those who had partial remission and 41% for those who had no remission. And the majority of those patients tended to have class 3 or 4 in their initial biopsies. When they compared the risk of doubling of serum creatinine with the histological parameters, basically they found that the rate of doubling of serum creatinine was statistically different among those who had persistent endocapillary proliferation or hypercellularity in their second biopsy, or presence of interstitial inflammation on their second biopsy, as opposed to those who had complete resolution of such lesions on their second biopsy. So those were patients who are at high risk of doubling of their serum creatinine if they had these histological changes upon their repeating biopsy. Now, when they did also survival analysis looking at the activity indices at the first biopsy, there was no difference in the renal survival analysis based on the activity indexes or chronicity index in the first biopsy. However, at the second biopsy, they noticed that the lower the activity index, the higher the renal survival, while the chronicity index on the repeat biopsy or the second biopsy did not make any survival difference. So the conclusion from the study that the second biopsy at the end of maintenance phase of therapy is an important diagnostic and prognostic tool that could guide physicians to safer practices with better outcomes. And it may allow tailoring the intensity of immunosuppression to the disease activity, which may result in reduction of both unwanted side effects of immunosuppression and the incidence of renal failure. The last study that would like to go over was published by Dr. Mitwalli in 2011 that looked at the effect of concomitant hepatitis C virus infection in patients with underlying lupus nephritis on long-term renal outcome. The aim of that study basically to assess the long-term impact of chronic hepatitis C infection in patients with underlying class 4 lupus nephritis on renal function, on progression to end-stage renal disease, and patient survival, given the high prevalence of hepatitis C in Saudi Arabia. So it was a retrospective study. They had a total of 134 non-dialysis dependent patients with biopsy-proven class 4 lupus nephritis with chronic hepatitis C infection. They were all adults above age of 18. All patients who were receiving dialysis or had previous dialysis were excluded from this trial. And all patients were screened for hepatitis C infection at the time of enrollment into the study were classified into two groups, those who have hepatitis C positive versus those who have hepatitis C negative group. They looked at the data between January 1995 until January 2008 at King Khalid University Hospital in Riyadh. Their primary and secondary endpoints were death or development of end-stage renal disease. Patients were followed for about 6.7 years. Steroid and cyclophosphamide was given to majority of patients, followed by azathioprine. None of the hepatitis C were treated with any antiviral therapy for hepatitis C. So when you look at the two groups, basically out of the 134, they had a total of 50 patients who are hepatitis C positive with lupus nephritis versus 119 who are hepatitis C negative, which gives an incidence of 11% of hepatitis C positivity in lupus nephritis patients. Significant difference in their baseline characteristics between the hepatitis C positive and hepatitis C negative lupus nephritis patients. However, when they looked at the renal function in patients with lupus nephritis and compared the two groups, hepatitis C negative versus positive, they found those patients who had renal impairment with creatinine above 350 tended to be present at a higher rate in patients who have hepatitis C positive, as opposed to those who are hepatitis C negative with lupus nephritis. 53% were having elevated creatinine versus those who in hepatitis C positive versus 22% in those who are hepatitis C negative. And when they compared the renal function in patients with lupus nephritis between at the time of admission and at the time of follow-up, they found again those who have hepatitis C positivity with lupus nephritis, they tended to have higher creatinine as opposed to those who were hepatitis C negative. And the creatinine clearance also was quite suppressed at the time of last follow-up in those who are hepatitis C positive as compared to those who are hepatitis C negative. In terms of renal outcome, in patients who with lupus nephritis and hepatitis infection, basically they actually found that those who have hepatitis C positive patients tended to have much more lower C3 level at the time of presentation, and tended to have higher death rate and end-stage renal disease if they have hepatitis C versus those who have no hepatitis C. So in conclusion from this study, basically concomitant hepatitis C infection in patients with lupus nephritis was associated with outcome and higher rate of progression to end-stage renal disease, as well as reduced patient survival. So the take-home message here from this presentation, basically lupus nephritis is considered the most common cause of secondary GN in Saudi Arabia. It is associated with significant morbidity and mortality. Class 4 is considered the most predominant diagnosis among lupus nephritis patients worldwide. MMF is the most widely used agent for induction. However, cyclosporine is still more used frequently than MMF, especially in those with severe disease presentation. Approximately 2/3 of patients with proliferative lupus nephritis, they developed remission in response to the standard induction therapy. And initial remission may predict long-term renal survival. The long-term, the response to treatment and long-term outcomes of Saudi patients with proliferative lupus nephritis is more comparable to that of non-Caucasian, including mixed race populations, and probably less favorable compared to Caucasian patients. Glomerular necrosis identified lupus nephritis patients who are at greater risk for progression to renal failure. Second, kidney biopsy will continue to be the most sensitive test to assess disease activity. Clinical and biochemical as well as histological parameters should be included for individualizing treatment decisions with more early and frequent therapy. Concomitant hepatitis C infection in patients with lupus nephritis has been found to be associated with worse renal outcome. And by this, I conclude my presentation, and I'm happy to receive any questions. Thank you so much.
Thank you very much, Dr. Zabani. I really enjoyed your talk. It's very informative, and it review all the Saudi studies in lupus nephritis in a very fabulous way. There are a lot of questions which I need to choose from, but before I start choosing, I have a question of my own. In my pediatric clinic, I have twin sisters. One of them presented with very severe proliferative glomerulonephritis and neurological lupus. And then after 1 month, her twin sister presented the same with proliferative nephritis and neurological symptoms. And on top of this, their mother has also lupus nephritis, for which she's receiving therapy. Because of this, I'm very hesitant to withdraw the maintenance therapy. So in Saudi Arabia, where genetic diseases and genetic background play a major factor, should we put this into consideration when we think about our therapy choices? Is there a study that looked at this? And your voice, Doctora.
Thank you so much, Dr. Adey. Basically, this is a very good question. And it is quite controversial what to do with the maintenance therapy in patients with SLE in general, not only lupus nephritis. But talking about lupus nephritis patients, we always, feel hesitant to stop or withdraw immunosuppression after finishing the maintenance phase of 2 years or even up to 3 years. However, I think the idea of doing second biopsy help to guide us what to do. I think if they present with severe presentation, not only lupus nephritis, but also with extrarenal manifestation that were severe, I think those patients, they deserve to be on a long-term maintenance therapy. And also if they had lupus nephritis with aggressive course, like if they had renal failure or they required dialysis at time of presentation, I think in those patients, I'll feel more hesitant to stop or withdraw their immunosuppression totally. Maybe some people, they have different point of view, but personally, I feel a bit hesitant to withdraw maintenance therapy completely in those patients who had severe presentation at the time of disease onset.
Excellent, thank you. So looking at the Q&A questions, one of the questions, what's the most specific investigation that differentiate lupus nephritis from other causes of nephritis? What do you find? Yes, go ahead.
Yeah, if I understand the question properly, I think biopsy is the gold standard to diagnose lupus nephritis because patients with lupus, they may develop renal failure for many other reasons, like TMA or chronic interstitial nephritis. They may have thrombotic events, other reasons for renal failure in SLE patients other than glomerulonephritis, if I understand the question correctly. So biopsy is the gold standard to make a definitive diagnosis of lupus nephritis.
Excellent. Another question, are those patients with lupus has high risk also to acquire COVID-19? A lot of the questions about COVID-19.
That's a very good question. I don't have data on that, honestly. I cannot answer this question. Sorry.
Fair enough. One question is asking, when do you recommend to repeat kidney biopsy in lupus nephritis and why?
Okay, well, basically, if you review the literature, most of the literature would suggest repeating the biopsy at the end of the maintenance therapy, which is anywhere between 12 to 18 months. But I would consider also repeating the biopsy if remission or partial remission before I consider minimizing or withdrawing immunosuppression. So basically, between 12 to 18 months, that's the right time to consider repeating the second biopsy to assess the response and to guide you what to do with the withdrawal of therapy, if you would withdraw therapy.
So another question is asking, probably when you presented the Professor Waida study, can we generalize this in all parts of Saudi Arabia? Could you generalize these results?
Well, it was a single center study. I cannot generalize it, but it's a good study, actually. They had a total of 52 cases. You mean the second biopsy or the study or the one with necrotic lesions?
Probably yeah, go ahead, sure.
No, I mean, the second biopsy was I believe, multi-center, but the one with necrotic lesion, it was single center. You know, we cannot always generalize unless you have multi-center randomized control trial, but I think we can extrapolate a very good result from these studies.
Totally agree. And the population seen in King Khalid, usually it's not just Riyadh. It's a referral center that received from all over Saudi Arabia. So another question, when do you recommend anti-CD20 therapy in lupus nephritis?
Very good. Well, guidelines, rituximab has been there, even though it has no proven evidence that it will change the renal outcome. And it's not even FDA approved to be given for lupus nephritis patients. But this is what, based on expert opinion, and some of the guidelines would recommend if patients did not respond to the standard induction therapy to consider rituximab. However, in my own practice, honestly speaking, I've had very good results with cyclophosphamide. When you catch those patients early on and you treat them aggressively with cyclophosphamide, then most of the time you achieve a good remission rate. I've never, in my own practice, I've never had to use rituximab as induction therapy.
Excellent. A question is asking about, do you recommend multi-target treatment during pregnancy and when to allow patients to get pregnant?
Okay, that's a very good question. So the multi-target therapy has been coming up in many studies. Of course, during pregnancy with multi-target therapy, because it is MMF based, you cannot use MMF during pregnancy. It's contraindicated as it is teratogenic. So that's not the standard of care. The only thing you can use during pregnancy basically is Imuran. That's the only safe immunosuppressant along with steroid.
Very good. I have another question of my own. In those patients who had a kidney transplant and you don't know what is the original disease, and then creatinine is increasing, you did the kidney biopsy, it showed a full house picture, but you checked the complement, which was normal, probably because the patient is already in immunosuppressant. How do you deal with these patients? And what to do to stop the rise in the creatinine?
Okay, very good. You mean recurrent lupus nephritis after renal transplantation? Well, this is a very good question. We always get asked about it. If you look at the recurrence rate of lupus nephritis post-kidney transplantation, it's quite rare. It's less than 10%. It's anywhere between 2 to 8%. I have never seen it in my 10 years of practice. I've never seen recurrent lupus nephritis, to tell you the truth. But if you ever see, I'm sure you will treat it the same way you treat lupus nephritis with the same induction therapy. It will not be different than any other people. You will treat it the same.
Another question about COVID-19. Does the vaccination induce relapse of lupus nephritis?
I have no idea, honestly. I cannot answer this question. Sorry.
Yeah. Okay, so I think we're done with the questions. Thank you very much, Doctora. Excellent presentation, and I really enjoyed it. Thank you.
Thank you so much. My pleasure. Thank you so much.
Thank you, Dr. Najla. Thank you, Dr. Dave, for really an elegant presentation and a professional moderator. Thank you very much, and we have to thank the GSK for their support, and we hope to see you all again. Please don't forget, we have another webinar in 2 weeks from now. It's going to be an excellent webinar about Khalid might take the floor to tell us about it, because that concerns him more.
Thank you very much, Professor Mutwalli. Thanks our colleagues today with the excellent enlightening us about the lupus in Saudi Arabia and revising most of our study. And this is actually what we can get from excellent collaborations, or I can say national studies. And this is really encouraging all of us to do more and more national studies about all renal disease. And Saudi Society of Nephrology Transplantation willing to support and anything they needed our researcher to support any national study. As the professor mentioned, in 2 weeks, we have another webinars. We continue giving our webinar at least once to 2 times a month. It will be about X-linked hypophosphatemia, and we hope all of you come and hear it. Thank you very much, and have a nice night, and see you in 2 weeks, inshallah. Ma as-salam.
Thank you so much.
We have to thank the event troop group for their technical support. Thank you very much indeed. Thank you, everybody. Warakum ala khair.